In the relapse setting, the field right now says that at least 3 drugs should be given, or 3 drugs rather than 2 drugs. There are multiple studies showing superiority for 3 drugs. In the newly diagnosed setting, it's the same thing. 3 drugs is better than 2 drugs. Up till recently, there were some controversy, and there were groups that argued that there should be some risk-adapted treatment, where they looked for the cytogenetic and FISH profile, and they assigned patients to high risk and standard risk. And they were saying that for standard risk patients, you could give as well 2 drugs, and it would be sufficient. But all the data show that that is not the right thing to do. You would have inferior outcome. You're better off treating the standard risk patients with the best therapies, and the high risk patients, they really need the best therapies. So do not use risk adapted treatment unless you really have to, if there are any contraindications or limitations otherwise. Should you use 3 drugs? Should you do 4 drugs? That's obviously the next question. With the new monoclonal antibodies, people have asked, can you just add them to the existing 3 drug combinations? The 3 drug combinations typically include proteasome inhibitors with an immunomodulatory drug and a low dose of steroid. So could you add either the CD38 antibody or some other antibody? There are many trials that are looking into this.